So that was the case of very severe aortoarteritis in which we had put through 4 stents and a blood pressure of 240 by 140 kdm to 130 by 80 with almost a normal looking lumen at the end of the intervention. We had seen her about 2 weeks ago. She is currently in Chennai and had a CT angio done, which showed the vessel still patent and the blood pressure under control. Next one, please. Yeah, this was a young boy who came to the medical OPD with history of recurrent melena. And they couldn't find the cause of melena, and he had a little murmur in the chest, and the hemoglobin was 3 grams. He was referred to us as a case to find out what the cause of murmur. It was 9:30 in the evening when he came to the hospital. I took him to the cath lab to find the curiosity to find out what the cause of bleeding. And we did an angiogram. Next one, please. We did a celiac angiogram which showed that there is a communication between the hepatic artery and the biliary system. So hepatobiliary fistula, the patient is to bleed from there, and when the blood pressure comes down, it gets thrombosed, the bleeding stops, again the blood pressure goes up, it will reopen and bleed again. So you had recurrent melena leading to a hemoglobin of 3 grams. At the end of that, we tried as to how to treat him now. So what we did was, we took a gel foam, 4 millimeter, rolled into an insulin syringe in form of a plug, loaded on the hub of a 6F catheter, and 5 cc of saline to push it into the fistula, and you see the stent blocking of the hepatobiliary fistula with complete cessation of bleeding instantaneously. Next one, please. Now, this is a girl who came with deep cyanosis. She has a very complex congenital heart disease, dextrocardia, with pulmonary atresia, with duct-dependent pulmonary circulation. And duct had a stenosis and the diameter of 1 millimeter. She had a saturation of about 64%, and the patient was very high risk. The family did not want her to be subjected to surgery, so we resorted to intervention. May I have the next slide, please? See, this is the MRI which showed that from the aorta, there is a PDA coming which is supplying the pulmonary artery. And the next one, please. This shows very tiny communication between the pulmonary artery and the ductus, 1 millimeter communication between the ductus and the pulmonary artery. Very severe ductal stenosis, and her whole circulation was dependent on this 1 millimeter communication. So what we did was, next one please, we tried to put a guide wire, PTCA guide wire, from there into the pulmonary artery and go into the left pulmonary artery base, and then put a PTCA balloon of 3 millimeters to dilate the 1 millimeter segment to 3 millimeters. And finally, we put in a stent, 6 millimeter, 15 millimeter renal stent into the ductal stenosis, which opened up beautifully. The saturation of 62% kept on jumping till it came to 95 to 96% at the end of the procedure. Next one, please. And you see here the pulmonary artery communication from PDA to pulmonary artery communication was 1 millimeter. At the end of the procedure, it was 6 millimeter wide, which is usually the size of aortopulmonary shunt carried out as a palliative to this kind of complex congenital anomaly. Next one, please. This is again a very interesting. A patient came to us with a huge AV malformation at the back. It was about 8 inches by 6 inches, pulsating, throbbing with a lot of bruit over it, and the skin was heavily stressed. Next one, please. So we tried to find out what is the cause of this, and we found that on the left side there are 4 frames. There are large feeding vessels coming from the descending aorta, which are going into the AV malformation and causing this huge hemangioma or AV malformation. And therefore, to treat this, we said, let's refer to surgeons. Surgeons refused because of high vascularity. The patient would die on the table itself. So we use vascular plugs. I think for the first time, possibly it was used in our country. I use vascular plugs in these 5 different feeding arteries. And you can see on the other panel, CT shows that those plugs have been implanted, and the feeding vessels have been completely occluded. The whole tumor came down from 8 inches to 4 inches by 2 inches. It slowly started decreasing, and therefore, what was a very difficult surgical endeavor has been handled by intervention in the cath lab. Next one, please. Well, this is a patient who came from another country. He had a very severe AR with the gross LV dysfunction, went to a corporate hospital where they offered 2 surgeries at the cost of 8 lakhs. The patient came to me. I said, no, we'll offer you 1 intervention and 1 surgery at the cost of 4 lakhs. And when I did the CT angio on him, he had a very severe cocktail of aorta at the age of 69 with gross aortic incompetence and severe LV dysfunction. You see, we're trying to get him from the groin to cross the coarctation. We're not able to cross. Then we connected both the radial arteries and then went down from there and crossed the coarctation. Next one, please. The coarctation was now crossed. You can see the coarctation segment. Next one, please. The catheter came down now, and through this the wire came, and this wire was snared and pulled out from the femoral artery. So you had a wire coming from the left brachial or radial into the aorta, descending aorta, into the right femoral artery, and you had access from below upwards now, or which we put now. The next one, please. We put a next one. This is the wire which has gone all through down. This has been snared out. Now you can see the snaring of the wire from the brachial artery into the femoral artery. Next one, please. And the next one. And now you are putting the catheter into the left subclavian artery. Next one, please. And you, next one, please. And now you are putting, next one, you're putting the stent. You're putting the balloon first to dilate. You can see the notch in the balloon on the left side panel, and on the other side you see the balloon dilated, so that there is dilatation of the coarctate segment. It has to be done very gradually, lest you caught dissection. Next one, please. It was further dilated by a larger balloon, and then a stent was put in. 16 mm, 40 mm stent was put in there. Next one, please. This was the stent put in. Slowly the stent is being deployed. You can see the neck on one side and is being completely dilated on the other. Next one, please. And you now see the stent in position, the coarctation taken care of. There is no gradient across the coarctate segments. Next one, please. This shows the CT angio, the aortic coarctation has been fully dilated and stented by this intervention. Next one, please. 7 days later, he was operated, aortic valve replacement was done, tissue valve was given. 10-day patient was discharged. By this hybrid technique of aortoplasty and stenting of coarctation of aorta and the aortic valve replacement, a challenging situation was solved in a sick and elderly patient. Next one, please. This is the girl who had come with the VST from left to right shunt. Next one, please. Next one. See, you put a wire from the femoral artery, gone into the aorta, crossing the aortic root, getting to the LV, crossing into the pulmonary artery, and straight from there into the pulmonary vein. Now, from the pulmonary vein, you have now pushed the sheath across to go into the VSD. The device is being implanted now. Next one, please. And you see now the device implanted on the left side with the VSD clearly seen. On the other, the VSD completely closed by a device put in through the percutaneous technique. Next one, please. This was, and again we see that the aortic root has been not affected. The aortic valve is competent completely. Next one, please. This is the case of very large PDA, blood pressure 120 by 80 in the aorta, 120 by 80 in the pulmonary artery. The saturation was in the upper extremity 99%, lower extremity 97%. Many doctors said that this is inoperable. But since saturation was 97%, I said maybe she's a large ductus. What we did, next one, please. So we did a special device which was custom made for her, 13 to 28 device across the ductus. Next one, please. And you see with that, sorry, can you go back there? And you can see the PA pressure fell down immediately, aorta being 120 by 70 and the PA being 60 by 40. So what was inoperable case has been done successfully in the cath lab by putting a large custom-built device for PDA. One of the largest device I think I have heard of. Next one, please. This is a lady who came with severe LV dysfunction. Angiogram showed 2 proximal lesions in the LAD and LCX. Angioplasty was done, a stent was implanted, and the LV function improved from 25% to almost 45%. Next one, please. So, ladies and gentlemen, let me summarize that interventional cardiology has been established in our country in a full measure as an alternative to surgery in several cardiovascular diseases. This has made possible to treat both pediatric and adult patients with a variety of cardiovascular conditions and disorders with excellent success. May I have the next slide, please? Ladies and gentlemen, my latest contribution is the textbook of cardiology I've written now. It was released on the 6th of December 2012 by the Vice President of India. This is the first textbook of cardiology in India written by Indian authors and has two important issues. One is not only that it is a pan-Indian authorship, it also has the multiple choice MCQs there so that the student can read the chapter, attempt the MCQ and see the results. This I hope and wish would be a service to our country. Thank you very much for a patient listening. God bless you.
Thank you, Dr. Khalilullah, sir. We all are privileged and honor to have a doctor from Vidarbh to do a first vulvoplasty in India, to pioneer that, teach to doctors in KM Bombay, and then head GB Pant Hospital for 17 years, now in Delhi, and also writing a textbook. We're really honored. Thank you.
I request Dr. Harish Bajaj sir to felicitate Dr. Khalilullah sir with my moment. I request Dr. T.C. Rathod sir to felicitate Dr. Harish Bajaj sir with moment. Our next lecture is on prevention and early detection in clinical medicine. For that, I would like to request Dr. Subedar and Dr. Mahajan to come on dais.
Dr. Subedar, ladies and gentlemen, we heard some wonderful talks about interventional cardiology to remove obstructions, very interesting talk on bariatric surgery for obesity relief, My message is the exactly opposite. 1 rupee spent on prevention will save 1,000 rupees on treatment. So in the next 20 minutes, I'm going to emphasize how by lifestyle modification and simple advice, you can prevent all those conditions, and therefore, for a country where 30 crore people are below the poverty line, my approach is the only feasible one. Inflammation is a topic of interest for every clinician. I gave an oration last year in Lucknow, and inflammation is such an ancient thing. For 2,500 years, clinicians know what is inflammation. Way back Calor, Rubor, Tumor, Feng Shui Lisa. It is only in the last 50 years that we know the mechanism of inflammation at the molecular level. Fever is the commonest manifestation of inflammation, and all of us physicians have to tackle with fever. And now we know at the molecular level how fever is caused. As little as 1 to 10 microgram of interleukin 6 or TNF alpha can produce fever. And we know how paracetamol works. It acts on the hypothalamic PGE3-2, and this is how the most common anti-inflammatory drug, we know the experiment at the molecular level. All of us clinicians deal with fever of unknown origin, and there are more than 200 conditions that we clinicians consider infection: HIV, extrapulmonary tuberculosis, endocarditis, autoimmune disease, lymphomas, familial fever. So all of us as clinicians are meeting with this problem of unknown origin. What is recent is atherosclerosis has inflammatory origin. This is a concept in the last 10 or 15 years, and this is a plan how atherosclerosis is inflammatory disease and how by dietary manipulation we can prevent atherosclerosis. We do not need statins for 90% people. What I am saying is not music to the drug industry. We have a dietary constituents, if we use regularly, can prevent atherosclerosis, because atherosclerosis is an inflammatory disease, and we have got anti-inflammatory strategies. Infection is a trigger for atherosclerosis. For instance, atherosclerotic lesions are found to contain chlamydia, pneumonia, HMV, and dentists also realize that periodontal infection can be the basis for macrophage activation and for the formation of cytokines. So dentists can help you to maintain dental health. By maintaining dental health, you can prevent the complications like atherosclerosis. NFKB activation is a key step in inflammation. In the last 20 years, we know very effectively what is NFKB, and NFKB activation is the central for all inflammation. What is interesting is, in our traditional Ayurvedic medicine, there are 10 common herbal drugs which suppress NFKB activation. This is the cheapest source of NFKB suppression, and therefore, the message is very important that by dietary phytochemicals, we can suppress NFKB inflammation in a most economical way. NFKB is also in malignancy. Infection and malignancy have a common trigger, NFKB activation. And NFKB activation promotes malignancy by transformation of tumor. NFKB family plays a central role in regulating the expression of genes essential for generation, both innate and adaptive immune response. Today we know in great detail how our immune system fights infection and how it prevents autoimmune disease. One important message of this slide is vitamin D is very important for immune competence. Every immune cell that you see here has a vitamin D receptor, and vitamin D receptor maintains the competence of immune cells. If you see in this audience, if you do your vitamin D level, at least 80% of you may have vitamin D less than 20. So you are all immunodeficient, and therefore, remember that apart from the effects on bone and joints and other things, vitamin D is a very important immune regulator, and vitamin D deficiency can make you more prone to infection, including tuberculosis. And therefore, a dietary level of vitamin D at least more than 30. 30 and above is desirable. 80 to 90 is actually the upper limit. So remember, all of us need vitamin D, and if you have not done it already, go and do your vitamin D. All housemen and registrars that I have seen in hospital, vitamin D less than 10. So the 11 o'clock tea break should be on the terrace of your hospital, where for 30 minutes you are exposed to sunlight. Cheapest prescription that one can think of. Importance of EPA. Our cell membrane contains 5% of EPA-DHA. Mother's milk is the best source of EPA-DHA. And therefore now pediatricians are saying that instead of breastfeeding up to 6 months, if possible, continue breastfeeding for 12 months to 18 months because EPA-DHA of cow's milk is the best source, 2:1. Cow's ghee is also a good source. Dara Singh used to take 250 milligrams of cow's ghee and he lived up to 85 years. So on this platform, take it from Dr. Lele as a very serious message that 12 spoons of cow's ghee will give you 1.5 grams of EPA-DHA and don't be afraid of cow's ghee, 12 grams. Take it from me that this is the cheapest source of omega-3 because fish oil vegetarians don't take and omega-3 which is purchased from the market, which you need 4 times a day. Simple message, at dinner also if you can manage to give 4 spoons of cow's ghee as a preventive measure for EPA-DHA. Why is it important? Now it is possible to measure the cell membrane EPA. The RBC membrane reflects membranes everywhere, including neurons. If your RBC membrane has less than 5% EPA, you make more pro-inflammatory cytokines and you make less anti-inflammatory cytokines, as shown here. On the left-hand side is arachidonic acid pathway, which makes pro-inflammatory cytokines. On the right-hand side, EPA-DHA makes anti-inflammatory cytokines. Even in the latest edition of Harrison 2012, there is no mention of anti-inflammatory cytokines, lipoxins, resolvins, protectins. So I have written to the editor, the 2012 edition of Harrison, which is the textbook all over the world, is very deficient because it does not mention anti-inflammatory cytokines. Resolution of infection or inflammation is not a passive process, it is an active process. So these resolvins and lipoxins are necessary for resolving. So if we do not have enough anti-inflammatory cytokines, all of us are constantly in a state of pro-inflammatory status. And the best way of assessing pro-inflammatory status is HSCRP. I would urge each one of you to have your own HSCRP at some time. Earlier it was ESR, now HSCRP. Anybody with HSCRP more than 5 is in a pro-inflammatory state. So remember that HSCRP should be the most common measure of inflammation and how dietary modification can bring it down. That's one very important take-home message. The other message is lipid peroxidation. F2-isoprostane. I am promoting F2-isoprostane as a test of lipid peroxidation. At any level of LDL cholesterol, total cholesterol, there is a small dense LDL which is important, which gets oxidized. So I would urge all of the clinicians to say F2-isoprostane. A kit is available, but most doctors don't know it. So HSCRP more than 5 and F2-isoprostane, these are the parameters of inflammatory state and therefore lifelong policy should be how to make the inflammatory state suppressed. Infection and cancer. As clinicians we know, if you have H. pylori, you may get gastric cancer. If you got HPV, you get cervical cancer. Herpes, Kaposi sarcoma, EBV lymphoma. So trigger for infection and trigger for cancer is common, namely NFKB, and that is how this slide shows the scope for prevention. Brain has the maximum oxidative stress and the concept of neuroinflammation. All degenerative disease is neuroinflammation, and that is how low EPA-DHA in the membranes of the brain make you prone to all these degenerative diseases. So brain EPA-DHA, people who take fish oil have less depression, less anxiety, and a therapeutic measure is to replace EPA-DHA so that many of these neurodegenerative disorders can be controlled. I gave a talk last time, Alzheimer's disease or type 3 diabetes, insulin resistance of the brain. Not many of you may be available this concept, so a few slides to show. Patients with type 2 diabetes have a 50% risk of developing Alzheimer's disease. And insulin resistance of Alzheimer's disease can occur independent of having diabetes. That's an important message. And reduced signaling in insulin-insulin receptor pathway and insulin receptor PIK-kinase pathway is the basis for insulin resistance. Insulin is a unique hormone. Unlike most other hormones that activate adrenal cyclase and cyclic AMP, insulin alone with ANP, BNP and nitric oxide stimulates cyclic GMP. Insulin has receptors in all tissues in which insulin has rapid, intermediate and delayed action. Insulin is necessary for neuronal survival. Not many of us have been taught that insulin is necessary for neuronal survival, neuronal plasticity, learning and memory, energy homeostasis, and reproductive endocrinology. Insulin and energy expenditure. It controls food intake, energy expenditure. Effects on the brain. Very interesting thing. By giving intranasal insulin, it can get absorbed to the hypothalamic campus region and goes to the hippocampus and has a trophic function there. The hippocampus has stem cells, and insulin, by reaching hippocampus, produces more stem cells, and that is how it improves memory. I will show some very interesting studies of how intranasal insulin directly goes into the CSF and directly goes to the hippocampus, does not go into circulation. So I'll show you some new data of aqueous intranasal insulin improving memory by increasing the hippocampal cell regeneration. This is a very useful slide. And here are some examples of how insulin reaches the hippocampus region and how it regenerates the hippocampal stem cells. Diabetes and depression. In the last Congress of Diabetes, it was said that 50% diabetics have depression. And I have got a theory that I have measured their glucocorticoid levels, and diabetics with depression have high glucocorticoid levels. So I postulate that high levels of glucocorticoids and depression cause insulin resistance in the brain. The very important message is caloric restriction. The WHO or the ICMR recommend for an average healthy man 2,400 calories. For a sedentary habit, 2,400 calories are excess calories. For a sedentary person, 1,600 calories. Remember this figure. If you're sedentary, 1,600 calories are ideal for you, and 1,300 calories give the least oxidative stress. The brain has the maximum oxidative stress, and increased calories increases the stress, and that is the basis for neuroinflammation and all the degenerative disease. So remember, if you can manage 1,600 calorie diet, in Ayurveda it described as sattvic ahar, kandamula phala. The rishis live for 100 years. What is the basis? Low calories, 1,300 calories, along with fruits, vegetables, and therefore the main message is, if you want to prevent metabolic syndrome, the best thing is caloric restriction. And by fruits and vegetables, you get a feeling of fullness, and therefore McDonald's, I have told McDonald's how to change their products in order to make them more friendly. They accepted my suggestion. So McDonald's food in future may be a different one based on the message that caloric intake is the enemy. Now, this is a very important slide which summarizes the whole message of my prevention. 1,600 calorie diet, regular exercise, and control of stress. These are the three things which will prevent all the diseases that we are going to discuss. It takes 10 minutes to speak to the patient and explain to him the importance of diet exercise. It takes 10 seconds to write a prescription. Unfortunately, doctors don't have 10 minutes to speak to the patient and educate him about diet exercise, and therefore they write 10 prescriptions. So my message to you is, a country which is very poor, 30 crore people are below the poverty line, they cannot afford statins, they cannot afford drugs, but they can afford exercise. Unfortunately, they cannot afford fruits and vegetables also. So in the villages at least, you can grow your own fruit. In the water that you use for bathing, in your backyard, you can grow vegetables and fruits. So the message is a low-calorie diet plus exercise. I'm showing here how adiponectin, exercise, metformin, all increase AMP kinase. So exercise for 45 minutes, along with a low-calorie diet, is the panacea for the future. At the age of 85, I do bicycle exercise for 45 minutes, and I sweat. There is no excuse that there is no time. If you have no time, while you are watching television, do cycling, and let it be shared in the family. So the message of exercise, the message of low-calorie diet is such that this will be the way for India. If by 2025, India is going to be the capital of diabetes, the prescription is today. If you are a diabetic, your 10-year-old child has metabolic syndrome. And I am promoting a new thought which all of you should practice. Pro-insulin to insulin ratio. I have shown by 1,000 diabetics, and Dr. Rathod showed me village people also. normal proinsulin to insulin ratio is less than 16%. If your proinsulin to insulin ratio is more than 20, it's a marker for metabolic syndrome. And if you are a diabetic and your 10-year-old child has a proinsulin to insulin ratio of more than, his lifestyle modification starts now. He should start